really focused on copying everything that I have, but I put page numbers on there so you can go back and look for it. Okay? So we talked about transmission. Tell me about transmission, someone.
They have a high penetrating power. They pass through all the way to the image receptor.
It doesn't necessarily have to be high. Yes, you're right on part of that sentence, Naomi. Thank you. It is X-rays that make it all the way through, but they don't necessarily have to be high. And the reason why I say that, because if nothing is blocking it, makes sense? Doesn't have to be high. It could be one of the lower end of the diagnostic range photons. So a lower KEV as long as nothing is blocking it. Makes sense? So transmission are the X-rays that make it all the way through to the image receptor without, let's be specific, without doing what?
Interacting.
Without touching the structures?
I like that. I like that. Not necessarily, but I like that.
Without getting absorbed?
Without having any attenuation. So this is without losing any photon energy or quantity. Now today we're going to spend some time talking about the photon energy and what it looks like. We already know what the symbol of a photon is, but now we're going to go back and figure out why it's that and what explains it. So transmission are X-ray photons that pass through the body without any interaction. True. However, it's transmission. They do not lose any of their energy. Theory, they don't interact with anything. But we're going to start to see that transmission is going to be based on energy level. Okay? So I need y'all to make sure y'all are reading ahead, because if not, you're going to be far behind. Okay? Because I want to change this up where you guys are telling me, helping me deliver the information, and not just me delivering the information. So when we think about differential absorption, what are the three things that we need for differential absorption?
Transmission, absorption, and Compton?
Scatter. Perfect. Perfect, Amy. Thank you so much. So we need all three. We will need transmission, we will need absorption, and we need limited amount of scatter. Scatter is not ideal, especially when it's in an abundance. And so we have different devices on how we can control scatter, because ultimately scatter degrades our image quality. Okay? And we call that what?
Is it fog?
Fog. Perfect. Good. So when we think about transmission, we think about energy. So here's our photon. Here we have it exiting. So we have 4 primary photons enter. We have 4 remnant photons exit. And they all reach the image receptor. Okay? Without losing any of its energy. So that's ultimately what transmission looks like. But when we go back and we say differential absorption, well, we need all three. We need transmission or penetration, and this is where our penetration power comes in. When I'm talking about penetration power, Daniel, what am I referring to? Penetration power.
I'm sorry, can you repeat the question?
What does penetration power mean when I'm referencing to the beam? Help them out.
The quality?
To the image receptor?
It is quality. Penetrating power is how well, or the energy of the photon. If the photon comes in and it's able to penetrate, it either is high KeV, 1, or there was nothing to intercept it. Make sense? So we're going to talk about transmission or penetration, absorption, because if we have a photon that has been completely absorbed into the body, it is not going to reach the image receptor. And then we have Compton. We have that primary photon enter, it got scattered, and now that photon is taking off into a different direction from what it initially was. So we need all three: penetration or transmission, absorption, or scatter. We need all three to make differential absorption. So when we think about this and we think about all of the processes from the X-ray tube, we know what happens in the X-ray tube. We know that we have a collimation assembly. We know what's happening when the photons exit the X-ray tube in the collimation assembly. We know now what happens when the photons enter or intersect matter. The object, whether it's a patient, whether it's a phantom, whatever it is, whatever the object is that is in between the source and the image receptor. We know that there are different interactions, two types of matter interactions, which are called
Is it photoelectric and Compton?
Absolutely. Perfect. So we see the depiction here. We have the primary beam. We have photons that never reach the image receptor. We have photons that exit the patient become remnant radiation that will hit the image receptor where it was aimed to hit. Here we have scatter. We have the Compton interaction happening inside of the body, and now the photon has changed direction, still reaches the image receptor. And we're going to know that as scatter radiation or fog. Okay? So, when you're thinking about why this is important, because if we're aiming our X-ray tube and we are positioning our image receptor correctly, the green strip goes to the top superiorly or the green strip goes to the right. We want to make sure that when we develop or process that image, the apices are going to sit at the top and the costophrenics are going to sit at the bottom, as they should, correct? Because we have learned how to view a patient. So all of this makes sense, because if the heart was to come down over here in the right lower corner, and then we had an apex over here on the lower left corner, it would not make sense. It would not represent what anatomy is, correct? That would be a pathology. Okay. So when we're thinking about what should we see, we've seen these words: opaque. We can say radio opaque. We know what that means. What we're looking at are the most common 5 radiographic opacities, meaning if we implement X-rays over air versus metal, where would we find metal at? On a radiograph. Where would we find metal at on a radiograph?
Maybe on a hip or...
Prosthesis.
Is that what you're asking?
Yeah, prosthesis. Good. Maybe a prosthesis. Where else? John? Where else would we find metal at?
In maybe the form of artifacts or doing floral, the doctor uses an instrument to find the position, to mark the position.
Absolutely. So prosthesis, artifacts. What is the most common metallic thing that we use to place on a radiograph, Dylan? To indicate side.
Couldn't hear it specifically.
I can hear you. What?
I couldn't hear what you asked me.
I said, what is the metal objects that we put on a radiograph to determine a patient's side?
The marker.
Markers. Perfect. So we have all of these 5 radiographic. My sound is going bad again? Yeah? It's going bad again? So when we're looking at it, we're looking at air, fat, soft tissue, bone. And you're thinking fat and soft tissue. You think, oh, that's probably the same. Not really. Not really. What's wrong now? Can y'all hear me? Okay. And then we're talking about metal. So what do these words mean? Because eventually we're going to get into these colors. We've already touched on these colors. We know what this color represents and what this color represents, right? We know that we have two extremes. We have high brightness or white, and we have low brightness or black. So what this basically means, the least opaque is going to be air and fat when we're talking about tissues. The most radiopaque, we're going to talk about bone and metal. The most lucent or radiolucent is going to be air fat. Make sense? The least radiolucent is going to be bone or metal. So it's basically saying what is the word that is being used. It's not the least and the most. It matters what we're talking about, radiopaque or radiolucent. The words can get tricky. The concepts don't. Make sense? Yes? Okay. When we start to look at X-ray exposure, now X-ray is going to be processed. We're going to develop or process the image so that we're able to see energy levels. Darkness or black or low brightness, because brightness is going to be our word. Brightness is going to be the word. So black or low brightness is indicative that X-rays penetrated very easily. Bright, high brightness or white means that X-rays did not penetrate easily. Got it? I want you to start thinking that ultimately X-rays, an X-ray screen is white, right? And that's pretty indicative. If you open up an X-ray screen, I don't think I have one in here, but we have some over at Kirby. It's white. So it's kind of like a sheet of paper. If X-rays do not reach the image receptor, it's going to stay white. But X-rays reach the image receptor, it is going to change in brightness levels. Okay?
So it's like
the higher the energy, the lower the brightness.
So
The lower the energy received, the higher the brightness. What kind of relationship is that?
Is it inverse?
It is inverse relationship. Absolutely. It is an inverse relationship, and this is how it's going to start looking. Any questions so far? So we're going to be talking about air, fat, muscle, bone, and metal. Okay? But the body's not really composed of a lot of metal, right? So we're going to mainly talk about this, but we know when metal is introduced to the body, such as repairs, it is going to absorb or appear high brightness. Make sense? Good. So let's talk about factors. We know technical factors. What controls beam quality, Isaias?
Come back.
Huh?
What did you say? Sorry.
I said, what controls beam quantity? Beam quantity.
It's mass.
Good. So we know what technical factors, but here I'm talking about factors, not technical factors, but factors affecting beam attenuation. What does beam attenuation mean, Jaleisha?
Attenuation. Attenuation. Isn't it the increase in thickness of the beam, I believe? Or intensity?
Think about the beam and think about the energy and the amount of photons. So it's the photon energy and the photon quantity. So attenuation means to do what? What is our definition of attenuation? That's okay. Help her out, Jessley.
the reduction of energy or X-ray photons?
So it is the reduction of either the energy of the photons, meaning you can still have the same quantity, but you've just reduced their energy level, or you've eliminated the quantity, some of the quantity from that beam. So either you've eliminated them through photoelectric absorption, or you've reduced the energy through which interaction?
Decreasing the mass?
If I have reduced the energy of the photon, but not have completely absorbed it, what interaction reduces the value of the photon?
Is it Compton?
Thank you, Compton. You guys have to put this together. So attenuation is both Compton interactions and photoelectric. They are not separate. And photoelectric absorption is the photon. Does the photon reach the image receptor, or is it completely lost inside of the body? Javier?
Is it get photoelectric's gonna be it's gonna be lost in the body.
So good. So is that part of the definition of attenuation?
Yes.
Yes.
Okay, good. Perfect. So you see where I'm going with this? A beam attenuation is referring to both Compton interaction and photoelectric absorption. Good. So what else affects beam attenuation, aka what else could affect photoelectric absorption and or Compton scattering? Well, tissue thickness does that. Increasing the tissue thickness increases beam attenuation. More photoelectric absorption and more Compton scatter. So increasing the tissue thickness, meaning layer on top of layer, is going to reduce the energy or the photon quantity of the beam. So here's an example. We have one layer of this material, and now we've added a second layer to this material. All of the material is being exposed to X-ray. So here, let's just have an example of 1,000 X-rays that are exposed onto the two layers. If you notice, the thicker, the double layer allows less X-rays to transmit or penetrate versus the thinner layer. The thinner layer allows more photons to transmit or penetrate. So indicating the thicker the tissue, the less penetration, or reverse. The thicker the tissue, more beam attenuation. Questions? Easy? I can move on? Perfect. All right, so there is a formula. So how do we know how to adjust our technical factors? How do we know how to adjust our technical factors for the amount of thickness? Well, there is a formula. Tissue thickness, X-rays are attenuated. So here our X-rays are going to be attenuated, either scattered or absorbed, exponentially. Meaning, if we have about 100 X-rays incident, as the tissue thickness increases, for each 4 to 5 centimeters of tissue thickness, we are going to reduce approximately about 50%. So we know for about 4 to 5 centimeters of tissue increase, we are going to lose half of our quantity. Any questions? I'm seeing some faces. I'm not sure what those faces mean. I'm not speaking anything other than English, maybe a little PRE-ish, but I am speaking, so let me know what you don't understand at this point before I continue to move. Okay, so here we go.
I'm
This is
sorry.
just another example.
Ms. Zara,
Yes, Mrs. Betty.
for every 4 to 5 centimeters of tissue, then does that mean that we decrease the mass?
Decrease or increase?
Increase.
Increase, absolutely.
Okay.
So here we have an example. We have different layers. We have the same amount of X-rays entering, same amount of incident X-rays or photons entering the tissue, but obviously it is exponentially resulting, meaning that if we know that the patient has increased by 4 to 5 centimeters, we know relatively how much more we should increase our mass. So, looking at this, now what does this look like? This is basically giving us an example of what it would look like on a radiograph. Okay? Radiograph. We know that low brightness means that there was more what, Stephanie? There was more what?
There's more air, more blackness.
What is this significant of? What is coming in and exiting?
The photons.
Photons. So we see low brightness means there was more transmission of photons, right? Over here, Tracy, we see less transmission, giving us what kind of brightness?
White.
High or low?
High.
Very good. High brightness. And then we have somewhere in the middle. This is going to be gray. People will say gray, 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 gray is going to be indicative of some type of scatter. Okay? So we have low brightness, high brightness, and then we have gray. But gray is going to have different levels or different shades as we're going to learn about it. Does anyone have any questions about tissue thickness, which is number 1 of the factors affecting beam attenuation? All right, so in a nutshell, what does this mean? The thicker the anatomic part, more X-rays are needed to produce a radiographic image. The thinner the anatomic part, the fewer X-rays are needed to produce radiographic image. So this is why we adjust our technical factors, our mass, for smaller patients because it's less thick as opposed to larger patients. Make sense? So pediatrics always have their own technical factors based on thickness. So the question here is, how do we measure thickness?
Some weight?
Not really, because I can see some people that probably weigh a lot less than what they look, or they look like they weigh a lot less than what they really are. So, how would we measure centimeters? Isn't that what we just talked about? What kind of unit of measure is centimeters?
Length.
Length. So what would we use to measure length?
Centimeters or inches?
Okay, centimeters or inches. We find that on a ruler, don't we? Don't we find that on a ruler? Yeah? Okay, good. Thank you, Ms. Jaleisha. So what device do we use in order to measure thickness in the radiology world?
Is a meter?
What is it?
Meter? Or
Meters, okay.
Yeah.
Centimeters, meter stick,
or
ruler,
caliber?
Are you talking about the caliper?
calipers.
Okay.
Calipers. Absolutely, calipers.
What are calipers, Jonan? I saw you talk. What is it? What are calipers?
It's just something that can open up to accommodate thicknesses so you can measure in between how thick it is. Huh?
Where have you seen that at?
In lab, when we measured for the knee.
Long has brought out some calipers, didn't he? And that basically measures, especially in the pelvic unit or in the leg, lower extremities, where to angle for a knee, right? Because we want to make sure that we angle parallel to the knee joint, the femur, and the tibia. So calipers are our device that measures thickness. So as a person increases, and let's just say I have a beautiful technique. I have a beautiful technique for this many centimeters. But guess what? Your patients aren't the same centimeters. So formula, math is going to be introduced soon, that you will start to calculate how much energy, quantity you need. Intensity. What does the word intensity mean?
Amount of X-ray.
Amount of X-ray, but also
The energy.
Power.
energy. So beam attenuation means the reduction of intensity, doesn't it? Yeah? Thank you. Good. So I can start to put words together from different chapters, and it still says the same thing. So we understand now, as thickness increases, X-rays need to increase. As thickness decreases, so do X-rays. What kind of relationship is that, Ruth?
Sorry, can you repeat the question? I'm sorry.
I can't hear you. What?
Can you repeat the question? Sorry.
What kind of relationship, as thickness increases, X-rays need to increase? As thickness decreases, X-rays need to decrease. What kind of relationship is that?
It's the inverse.
Directly proportional.
If something goes up, the other goes up. If something goes down, the other goes down. Help her
The
out,
inverse
Marisela.
relationship.
Marisela?
Proportional.
Oh, I'm sorry. Did you say it, Ruth?
Yes, I said the inverse relationship.
Inverse means something goes up and then the result goes down.
Directly proportional?
Directly proportional. It is directly meaning something goes up, something else needs to go up. Something goes down, something else needs to go down. Okay? So thickness. Now that was talking about X-rays. Luke. Yeah, I called you. If thickness increases, what happens to attenuation? Beam attenuation.
That increases as well.
That increases as well, doesn't it? The thicker the tissue, the more beam attenuation. What kind of relationship is that?
Directly proportional.
Beautiful. Marisela, I have another one for you. If thickness increases, what happens to transmission?
Decreases.
Does it decrease?
I'm sorry?
Does it decrease?
Okay, so what kind of, good. So if thickness increases, transmission decreases, what kind of relationship is that?
Inversely proportional.
Inverse. Perfect. Awesome. So you guys are getting it. I love it. All right, number 2. Do we have any questions about tissue thickness before we go into type of tissue? All right, type of tissue. Now, this basically means what kind of tissue are we talking about? Are we talking about bone? Are we talking about soft tissue? Or are we talking about air? Okay? Air. The alveolar sacs. Alveolar sacs that contain what inside of the lungs? I can wait.
Is it the brachials or the, oh,
I'm sorry?
You said what does alveoli contain? They contain air.
Thank you. They contain air. So air is considered a type of tissue because we need it. We need it. We need it for an exchange. Air for carbon dioxide. So type of tissue is important. The atomic number makes a difference. So when the atomic number is high of the element or type of tissue that we're talking about, has the ability to attenuate more of the X-ray beam, as opposed to an atomic lower number. Okay, so here they're using the example of bone and fat. Let's take a look at the diagram. Here we have X-rays. They're all relatively about the same energy level, and we're going to talk about how we know. As the X-rays are going through bone, there's more attenuation happening. How can I tell, Tracy?
can you repeat the question?
Help her out, son.
I'm sorry, like, what's the question?
Okay, let me go ahead and go because I'm talking and I see distractions. That's what I see. What I'm saying is there's primary beam entering. There's more attenuation. How do I know? Because there is less remnant. There is less remnant. Here, there is less attenuation because there is more remnant. Make sense? Yes? So more X-rays are reaching the image receptor around the air than there is bone, indicating there's more beam attenuation. So don't lose focus on what beam attenuation is. Got it? Please remember the definitions. Key terms are going to be huge for your final exam. So here we have air. We know that it has a high or a low atomic number. Pamela, does air have a high or a low atomic number?
I believe it has like a high atomic number.
I would say a low atomic
Can you
number.
hear me?
Air is pretty loose. Air is pretty loose. Look at the color.
I'm sorry, it's a low.
It is a very much the lowest on the entire spectrum. So here we have a low atomic number versus a high atomic number. A low atomic number tissue will attenuate less. A high atomic number will attenuate more. You can get easily lost in the words. So again, I highly encourage you to write out your definitions. Study your definitions. Dissect your definitions so that you understand what is being said. Any questions on atomic number? No? All right. Factors affecting beam attenuation number 3, tissue density. Tissue density. Tissue density is basically how compact the tissue is. Here we have an example of muscle versus fat. We have 1 pound of each. So generally they are the same weight. 1 pound of fat, 1 pound of muscle. However, tissue density is saying volume of tissue per unit mass. We have more tissue per unit mass, meaning we have smaller tissue sample at the weight of 1 pound versus larger tissue sample at the weight of 1 pound. X-rays are likely to pass through this easier than this compact tissue, fibrous tissue of muscle. Think about it. When you're eating something, let's just say you're eating steak, right? If you're eating steak, you can very well tell what is fatty versus muscle. How can you tell?
Is it softer?
It's softer, easier to cut, isn't it? Or easy to chew. If it's tough, it's hard to even get through it with your teeth or your knife, correct? So if it's extremely tough, think about how X-rays are going to fit through it. If it's very compact, X-rays are not likely to fit through it without interacting, either through Compton or photoelectric absorption. So if it is more compact, less transmission. If it's very loose, less compact, then you're going to likely have more transmission. Make sense? Because there's more volume of tissue per unit area. Less. There's so much more here, right? But it's very loose. It's not as compact. 5 pounds is equivalent to 5 pounds. However, tough tissue, loose, soft tissue. Okay? So now we're taking it. Okay, so that was between fat and muscle. How do we know when we're looking at muscle versus bone? Well, let's take a look at muscle again. We know that muscle cells look very specific. They're specialized cells, therefore moving the skeleton, right? They're for moving the skeleton. The skeleton will not move on its own without muscles. Muscles will not look like muscles unless they have the structural stability of the skeleton. So we have compact, tight tissue, but it has the ability to move. It has the ability to expand. It has the ability to wither, atrophy. Okay? But skeletal muscle, unless it starts to lose its mineral, will relatively stay the same. I want you to pay attention to this compact outer area. Look how compact the cells are together. They're squished, not allowing a lot of X-rays to pass through. More likely to be absorbed in that type of tissue. So tissue density does not mean atomic number. Tissue density does not mean tissue thickness. Tissue density means how compact the bones are. Make sense? Questions? So let's take a look at an example and say we have 30 keV versus 100 keV. Now we're looking at compactness, or you can tissue density, and however you can say atomic number. At 30 keV, and this is just an example, we're just talking about lower transmission for the bone. This is where sometimes, no matter what you're X-raying, no matter what you're going to X-ray, we can have more transmission by adjusting our technical factors. What are we adjusting? We're adjusting our kVp. In order to get higher energy, we're not talking about quantity. 1, 2, 3, 4, 5, 6. 1, 2, 3, same thing. What we're talking about is higher penetrating power. That is our kVp. So if we want more transmission from the bone, then we would just have to do what? Boost up our
KVP. Increase the KVP.
Increase the KVP. So that brings us into our next one. This is our fourth and final factor affecting beam attenuation. So how do we affect beam attenuation besides thickness, besides density, besides atomic number? We can talk about beam quality. Higher penetrating X-rays. Higher penetrating X-rays, we know that we increase the beam quality. Higher penetrating X-rays means a better beam quality. Lower penetrating X-rays means that we've lowered our beam quality. We're going to look at waves. We're going to look at waves to determine what is their wavelength versus their frequency. We're going to look at waves, look at their wavelength and their frequency. Because describing the wave, shorter and higher frequency, longer and lower frequency, will be a characteristic of what type of beam quality you're talking about. A shorter wavelength with a higher frequency is indicative of higher penetrating X-rays, which will likely transmit through anatomic tissue without interacting with the tissues, period. So more transmission. Lower penetrating X-rays have a longer wavelength and a lower frequency. They're more likely to interact with structures or beam attenuation. Higher beam quality, more transmission. Lower beam quality, likelier for beam attenuation.
Can you please repeat where you said the increase? You said higher penetrating X-rays increase the beam quality.
Transmission.
Okay. Thank you.
And cause transmission.
Thank you.
Mm-hmm. So I'm going to take a break right now, about 5 minutes. If you need to go up, go do what you have to do because I'm starting a different section. For those that want me to go back over this, please do so. Now is your time to ask any part of the 4 factors that are affecting beam attenuation. If you notice, I did not talk about technical factors. We will talk about X-ray beam quality, but we're also going to talk about that in the form of frequency versus wavelength.
Laura, just to verify, I'm sorry, like that audio, I couldn't hear you for a moment. It was density, atomic number, beam quality, the X-ray beam quality.
What are you? Okay, I'm sorry. What are you asking? Are you asking about the 4 factors?
Yes.
So you have tissue thickness, tissue density, atomic number, and beam quality.
Thank you.
Mm-hmm.
Miss Laura, for X-ray beam quality, you said that shorter wavelength means that it's a higher penetrating, so it gives us more transmission, right? So for the longer wavelength, and that's for the shorter penetrating. So you said it's likelier for beam attenuation?
Yes. What is beam attenuation? If longer wavelength or lower frequencies are likely to cause more interaction, are they likely to cause more more transmission? No. Transmission is the opposite of attenuation. You cannot have transmission and attenuation at the same time. It's almost like saying you cannot have penetration and absorption at the same time.
Thank you.
Mm-hmm.
Ms. Laura, can I ask a question? It's not really about it ties into the lecture, but it's something I saw in clinical actually.
Okay.
So I was in bone clinic and we had this patient they had to do a scoliosis series on.
Mm-hmm.
He was a big guy, he was 6'3", 330 pounds.
Mm-hmm.
And when it got down to the half section, like the machine, like it wasn't working. Like it kept saying, like, I guess the radiation, nothing, I guess, was transmitting. Is that what was happening? I'm assuming.
Yep.
Okay.
So
I mean,
basically, so what people use is AEC. And AEC, AEC is going to be regulated by sensors in the image receptor. Not in the image receptor, but on the actual Bucky itself. So the AEC is a sensor on the Bucky that terminates the switch when it has received the right amount of energy, right? For differential absorption. So if the person had a large abdomen, as you're kind of indicating, yeah, he's 6'3", could be muscular. However, penetrating the abdomen on men, because men, you said male, right?
yes.
Okay. Male usually their weight is disproportional. It doesn't go usually all over the body. It usually stays closely in the abdominal area. And so on top of the abdominal adipose and the organs and the lumbar spine and the muscle, sometimes you will cause the AEC to shoot up in mass. Well, after a certain amount of mass, your energy, your space charge effect, all of that will start to shut it down, or it'll give you a warning saying, oh, heat overload, heat overload. So basically, it's a safety mechanism so that you're not over penetrating a person, because ideally, you can't, in our diagnostic range, you can't go past beyond a certain amount, because then it's considered negligent or hazardous. So what probably happened there was the backup timer for the AEC wasn't set high enough. And so there was probably a premature termination because the energy was too high for what the equipment could do.
Okay.
Yeah.
Okay.
Yeah.
She did it. She did it this. Okay. She did it a second time. I don't think she changed anything. She was just basically like praying that it went through. It worked.
You can do two things. Now, even though there are two things that you can do, you can back up your backup timer. You can increase it. So you have to do a technical change, or it's not ideal, but I probably would have put the patient PA to compress the abdomen, because now you're compressing the thickness. So you're taking soft tissue, compressing it, it'll allow the x-rays to go through. Yeah, there'll be OID of the part, but you will at least be able to see something relatively to nothing.
So you literally just like would put them up against the Bucky and just like have them like hold like, tight up against it.
And if the patient can, I would have them compress their abdomen, like hold on, shrink or lessen the thickness so that the x-rays can go through. Yeah, it provides a little bit more compression or compactness, but not as much like it would be muscle or bone or something and so forth. So you can have them compress their abdomen, or you can increase your technical factors.
So you said the technical factor you'd increase was increasing the backup time?
Backup timer, because remember, if they're using AEC, they're using a sensor in the device. Unless you're doing a manual technique, or I could choose a manual technique, eliminate AEC, go to a manual technique, and no matter what I gave was going to transmit all the way through the patient or absorb or whatever.
Okay, so that backup timer, that timer that's just a sensor for it to say, okay, you've been giving up too much radiation. It needs to stop.
Right, it's just a tool, and we don't necessarily have to use it. And so when we get to that next semester, you'll understand why. So we're the brains of the operation. So I could have increased my backup timer for my AEC, eliminate AEC altogether and choose a manual technique, or apply compression. For the patient, but I probably would have applied compression without AEC.
Gotcha. Okay, yeah, I still didn't really understand like what had gone wrong there, so I wanted to bring it up.
It's the backup timer. If I set my backup timer for 3 seconds, which you needed 5, it was going to cut off at 3, no matter what.
Okay, I gotcha. All right, thank you.
You're welcome. Anybody else have any questions about factors affecting beam attenuation? I know this takes a minute to get your head wrapped around it. I know it's a lot, but you gotta learn your terms. There's no way around it. You gotta know your terms. Okay? Okay, so I'm assuming everyone is back. When we're talking about the electromagnetic spectrum, if you want some of this information, I believe it's in your chapter 3. It is in your chapter 3. I believe it's in your chapter 3 of your book. So when we're talking about electromagnetic spectrum, we're talking about this wavelength. I don't need you to go back and read all of chapter 3. What I really need you to know is right here, and we have our symbols. What does this depict, Naomi? What is this? What is this? What is this a symbol of?
That's the sine wave, and we use it for
is the
the
sine
photon.
wave, where we use for photons or X-rays or energy, correct? So as I'm looking at this, and I'm looking at the spectrum, here we have microwaves, infrared, visible light. Visible light is the center of the spectrum. I don't need you to know what necessarily is the electromagnetic spectrum, other than you're going to find energy levels on the electromagnetic spectrum. So what we see is a sine wave. We see a sine wave from the highest on the electromagnetic spectrum, which is around gamma and X. And then we have radio waves, which the sine wave starts to change. So let's take a look at what is a sine wave. Here, this right here is a sine wave, and we have learned this to be the symbol of our energy, our photon, our X-ray energy. Here, at the very bottom, we call this the TROUGH, T-R-O-U-G-H, TROUGH, T-R-O-U-G-H, TROUGH, T-R-O-U-G-H. At the very top, kind of like an ocean wave, right? Ocean wave. We have the crest, C-R-E-S-T, crest, C-R-E-S-T, crest. So we have the TROUGH and we have the crest. The lowest point is at the TROUGH. At the highest point, we have the crest. When we are thinking about a sine wave, it looks like an ocean wave, right? And we know that this is going to be indicating what our energy looks like. So in your book, in chapter 3, this is the definition of electromagnetic wave measures. And the reason why I'm getting into this is because we were talking about the fourth beam quality. The electromagnetic wave may be described by its wavelength. I'm not going to get too much into amplitude right now, but wavelength, distance from one peak crest to the next. Distance from one peak or crest to the next. Frequency means the number of waves that pass at a given point per second. So second is beep, right? It's a distance of time. Time, second, the unit measure of time. So when we think about wavelength, distance from one peak or crest to the next, and frequency, the number of waves that pass a given point per second, it determines what type of wave strength or energy we're looking at. So let's take these two examples. Here we have a crest, crest or peak, crest, and here we have another one, right? And here we have another one. On this one, we have peak, peak, crest, crest, whatever, it doesn't matter, right? Same words, same thing. Here we have a trough to a trough to a trough, so on and so forth. And sometimes they're referred to as valleys, peaks and valleys. What it's basically saying, the wavelength is from one peak or crest to another. So here, if I were to take this off, I would say this is one wavelength. This is the distance from here to here. Make sense? And from here to here, relatively the same. Now I'm comparing the distance, the wavelength, the distance from here to here. Which one has a smaller or shorter distance, A or B, between crests
B.
or peaks?
B.
B. Perfect. B. So if we have a smaller or shorter distance, then guess what? We have the ability to have more waves. So here we have 1 wave, 2 wave, 3 wave, right? And let's just say this was 1 second. Here we're able to have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 waves in 1 second. Frequency determines how many waves are in that given point. So we had more waves in B than we did A for the same amount of time, 1 second. So which one has a higher frequency, meaning higher repetitions of waves? B. Perfect. So we have more waves in B than we do in A because we've shortened the wavelength. Correct? I'll say that again. If we have a larger wavelength, we have less waves in a given time. If we shorten the wavelength, same time did not change, we have the ability to put more waves in. So here we have a higher wavelength. Here we have higher frequency. The next question that I'm going to ask is what is the relationship between frequency and wavelength? If I have a larger wavelength, what happens to my frequency?
Is it not as intense?
Less frequencies.
Less frequency. Perfect. Perfect. Thank you, son. But if I have a shorter wavelength, what happens to my frequency? It goes higher. So these two, frequency and wavelength, have an inverse relationship. Frequency and wavelength have an inverse relationship. Frequency and wavelength have an inverse relationship. If frequency goes up, wavelength goes down. If wavelength goes up, frequency goes down because time will always stay constant. If I expose an image for 2 seconds, that is my time. It stays constant. However, energy of the wave will increase if I increase my frequency. So let's take a look. Which one of the two has a higher frequency? The left or the right?
The left?
The right. Look at the waves. 1, 2, 3 versus 1, 2, 3, 4, 5. Does everyone see it? Yes, I see everyone typing it in. The right has a shorter wavelength and higher frequency. So if you see this wave, it is higher frequency or higher energy than this one. So it's easy to say, or it's relatively accurate to say, the higher the energy, the more likely you're going to have transmission. The lower the energy, the fewer the X-rays will penetrate or transmit. So looking at the symbols and looking at the wavelength versus frequency, greater wavelength, shorter wavelength, right? Greater wavelength, if I took a ruler from here to here, it's going to be larger than it is from here to here. So the pictures are speaking to us. I like when pictures speak to us. They make sense to me. They should make sense to you. So here we have it. This is back to what we were saying. Higher energy, higher quality of the beam is going to give us more transmission. True? Right? Higher energy or beam quality will lower beam attenuation. Is that true? Uh-oh, what did I say? What did I say? Did I speak in riddles?
Can you speak again?
If I increase energy of my beam, will I lower beam attenuation? No?
Yes.
No.
Yes.
Absolutely. Yes. What is the opposite of beam attenuation doing? Opposite. If beam attenuation means scattering and absorption, what is the opposite of that? Transmission. So if I increase beam attenuation, would more X-rays exit the patient? So now I said higher energy will decrease beam attenuation. That means lower absorption and scattering, meaning more transmission. Make sense? Oh, it's riddle time, isn't it? I warned y'all last semester PRE was going to be in the brain. In the brain. Okay, talk to me, because we're moving on to a chart, and I love charts. I love charts. Okay, so this is where I'm going to get to call on you. Let's see, who do I start with? Sun. If tissue thickness increases, what happens to my beam attenuation? Does it increase or decrease?
Increase.
It does increase. Now, I don't understand why they did this, because beam attenuation does take on absorption, right? But for whatever purposes, whether they're meeting this as Compton and whether this is just solely photoelectric absorption, fine. So if beam attenuation increases with thickness, so does absorption. What happens to transmission, son?
It should decrease, right?
I can't hear you, son.
Oh. I'm sorry?
What happens to transmission if increasing thickness increases beam attenuation along with absorption? What happens to transmission?
Less transmissions.
Less. Perfect.
Less transmissions.
Absolutely. You cannot have both. You cannot
Yeah.
have an increase on beam attenuation and an increase on transmission. These two are completely, well, these two
Inverse.
are completely opposite of each other.
Yeah.
Good.
Inverse.
Perfect. So I'm going to skip decreasing thickness because those were just reversed. Tracy, tissue atomic number increases. What happens to beam attenuation?
I believe that would decrease.
Decrease?
Yeah.
Is that what you said?
Yes.
Think about it. What's increasing? The atomic number. What does that mean?
It would increase. The
Tell me now. Tell me now. No, I don't think I'm convinced now. Tell me how.
because the increase in the photons.
How so?
Because the atomic number correlates to
It's
the
not the photon atomic number that is changing. That has already been determined by the tungsten atom inside of the tube. That has no correlation to the atomic number of matter. Help her out, Stephanie. Tissue atomic number goes up. What happens to beam attenuation?
Does it go up?
It does go up.
Yep.
Because that means we have more orbiting electrons, don't we, inside of that matter. And if we have more orbiting electrons inside of that matter, chances are it is going to either be Compton interacted or absorbed. Perfect. So if increasing atomic number increases beam attenuation and absorption, what happens to transmission? Stephanie?
Decreases.
It decreases. Perfect. Jaleisha, tissue density. As tissue density decreases, what happens to beam attenuation and absorption? Because these two are going to stay together.
If the density is decreasing, shouldn't it? Density is increasing, then shouldn't it also decrease?
It should also decrease. So tissue density is decreasing, absorption is likely to go down, and transmission is likely to go up. Now, beam quality starts to change things. Beam quality starts to change things. As beam quality increases, beam attenuation goes down, transmission also increases. Now, if you can go back and look at these arrows, and I don't want you to get too confused because beam quality, as I taught you back in last chapter, if we said beam attenuation by definition is the reduction of energy and quantity. Absorption is the total loss, right? It's the total loss of photons exiting. So this one and this one are going to have exact opposite effects. I don't want you to get confused here. But what happens when I increase KVP, Jonan? What happens to Compton?
It increases.
Absolutely. It also increases. Now, that's always the question to come back and say, well, Ms. Lara, I thought when we increase beam quality, we also increase Compton interactions, and we do. We do. However, this resource wants you to stay focused and not incorporate all of the excess scatter, because I guess it's going to also incorporate cleanup. Okay? Cleanup. So here you have your chart. You guys can go back, use this as practice. Use this as practice because on your exam, I will have these words and you will have to select increase or decrease. Okay? Oh, that's weird. Any questions? Now, if the easiest way for you to go back and learn it is absorption and transmission, meaning opposites, right? You can always go back and look at beam attenuation because absorption falls into beam attenuation. Didn't we say that earlier? What is absorption? What kind of interaction is this called?
Photoelectric.
Photoelectric absorption. That's why I always say it together, photoelectric absorption. So we know photoelectric absorption is part of beam attenuation. Beam attenuation is Compton interactions in photoelectric absorption. So I am going to stop here. I do need you guys to read ahead. This is complicated material because the words can and will change on you. This is not about memorization, truly not about memorization. It is about comprehension because it is too easy for me to change these words. Look at the inverse and direct relationships. Look at the inverse and direct relationships. Does everyone understand what I mean by that? Look at the arrows. As something increases, what increases? As this increases, what decreases? Make sense? So go back and practice this chart. It is essential for chapter 8. Know your words: beam attenuation, absorption, transmission. All three of those, well, Compton scatter, is differential absorption. Got it? What other words were? Sine waves, frequency versus wavelength. What determines beam quality? A high frequency, the higher the energy or higher the quality. A lower frequency, the lower the quality. The longer the wavelength, the lower the quality. The shorter the wavelength, the higher the quality. Questions? I know. Y'all are staring at me like, what? How do I make this simple? Key terms. Really dissecting your key terms. Going back and rereading it word for word. Okay, talk to me. What's going on? No? Yes? Pretty easy? Am I thinking it's more complicated than what it really is? Guys got it down? The 4 factors?
My head.
Yeah? The differences between tissue density, tissue thickness, atomic number, and beam quality. All will play a part in what? What have we been talking about this whole lecture?
Attenuation.
Beam attenuation. Thank you, Esbedi. Beam attenuation. Okay. Y'all have no questions. I'm done. Keep reading. A lot more information to cover. Okay? All right. Talk to you later.